Hello everyone and welcome to our module on thrombocytopenia. Before we talk about thrombocytopenia, let's briefly review how platelets function because understanding this is very important to understanding all the causes of thrombocytopenia we'll talk about later. So platelets circulate in an inactive state, but they can become activated, and when that happens, this leads to formation of a thrombus. Platelets together with fibrin from the coagulation cascade are what make up blood clots or a thrombus. In order for platelets to function, they need some help from factors in the plasma and also surface molecules on the platelet itself. The first thing they need is von Willebrand factor. This is a glycoprotein. It's produced by endothelial cells and megakaryocytes, and it binds platelets together and also binds platelets to damaged endothelium. So von Willebrand factor is necessary for platelet thrombi to form. And then GP1B, or glycoprotein 1B, is a platelet surface molecule. It binds the platelet to von Willebrand factor, and therefore it assists in linking the platelet up to von Willebrand factor and forming a thrombus. And then similarly, the platelet surface molecule GP2B3A also binds to von Willebrand factor. It can also bind to fibrinogen, but once again it helps to link the platelet up to other factors in the formation of a thrombus. Let's talk briefly about the different types of bleeding you can see when there's a problem with the coagulation system and a problem forming blood clots. If the platelets are abnormal, if they're either not working or the platelet count is very low, then this more often leads to bleeding in the skin and bleeding on mucosal surfaces like the gums. Also, when the platelets aren't working or the platelet count gets very low, you can see petechiae, which are pinpoint round spots on the skin. This is a picture of petechiae on the slide here. They look like these small round spots. And then sometimes some of the petechiae coalesce together, and when this happens, this is called purpura. In contrast, if there's an abnormality of coagulation factors, this more often leads to joint bleeding and deep tissue bleeding. For example, in children who have hemophilia who are deficient in clotting factors, they classically present with joint bleeding, and you usually don't see petechiae or purpura in those situations. The definition of thrombocytopenia is a platelet count below 150,000. The normal range for a platelet count is 150,000 to 400,000. You should be aware, however, that the risk of a major bleeding problem only occurs when the thrombocytopenia is severe, which is usually defined as less than 50,000. There's a long list of causes of thrombocytopenia. The list is enormous, and we'll go through just some of the important ones in this video today. You should be aware, however, that when a patient presents with asymptomatic isolated thrombocytopenia, meaning the red cell count and the white cell count are both normal, this is most commonly immune thrombocytopenia, or ITP, which we'll talk about later. On the other hand, in hospitalized patients who have thrombocytopenia, there's a long list of causes. This can be platelet consumption due to disease, this could be bone marrow suppression, this could be drugs, and the workup of a hospitalized patient with thrombocytopenia depends highly on the context in which the thrombocytopenia occurs. Here's a table from the White Coat Companion summarizing many of the causes of thrombocytopenia. As you can see, it's a very long list, and in general, when patients have low platelets, you don't go looking for every one of these causes. It's very context specific depending upon the patient's history, clinical exam, and the drugs that they are taking. The treatment of thrombocytopenia can involve platelet transfusions. There are various cutoffs that are used for when to transfuse based on specific patient scenarios. Some of the commonly used thresholds include a patient who is bleeding and has a platelet count less than 50,000. This is often an indication for a platelet transfusion. Along those same lines, if surgery is planned and bleeding is anticipated and the platelet count is under 50,000, this is also often an indication for transfusion. In patients who aren't bleeding and in whom surgery is not planned, where you're simply trying to prevent spontaneous bleeding, usually for bleeding prevention, platelets aren't transfused unless the count gets very low, less than 10,000. And that's because spontaneous bleeding events are very unlikely until the platelet count gets down to this level. You should be aware that platelets express ABO antigens on their surface, just like red cells. So ideally, you match the blood type of the transfusion to the patient. This will result in a greater increase in platelets. You should be aware, however, that mismatched platelets in terms of ABO blood type are sometimes used, especially when the inventory in the blood bank is low. This will still work, but you get less of a rise in the platelets compared to what you would get if the blood type were matched. And the reason this is done is because transfusion reactions like allergic reactions to mismatched platelets are uncommon. They can occur, but they're much less common compared with red cells. Now let's talk about two congenital platelet disorders. Both of these disorders are very rare, and for your board exams, you just want to have heard of them in case they come up in a board question. They both present with platelet-type bleeding in a child. The first is Bernard-Soulier syndrome, which is an autosomal recessive disorder where children have a deficiency of the GP1b platelet receptor. This is that receptor we talked about earlier on the surface of platelet cells that binds von Willebrand factor. So these children have platelets that cannot bind von Willebrand factor, and therefore they cannot form blood clots normally. This leads to platelet-type bleeding, and then on a workup, these children have thrombocytopenia, and classically they have giant platelets in their peripheral blood smear. This is a picture of a giant platelet on the slide here. There are a number of rare childhood disorders that lead to giant platelets, and Bernard-Soulier syndrome is one of them. The second disorder is Glanzmann's thrombasthenia. This is also an autosomal recessive disorder, and children with this condition have a functional deficiency of the GP2B3A receptor. Basically, part of the receptor is not normal, and therefore it doesn't function normally. And so as we discussed earlier, you need this receptor for platelets to bind to von Willebrand factor and fibrinogen to form blood clots. So these children have platelet-type bleeding, but their platelet count is usually normal, and the classic finding on a peripheral blood smear is isolated platelets with no clumping because the platelets are unable to clump together. You can also stimulate the platelets to try and make them aggregate together, but there will be absent platelet aggregation in Glanzmann's thrombasthenia. Okay, now let's talk about immune thrombocytopenia, also sometimes called idiopathic thrombocytopenic purpura or ITP. This is a disorder of decreased platelet survival. In immune thrombocytopenia, platelets are consumed by splenic macrophages, and this consumption leads to thrombocytopenia. And commonly this is caused because of anti-GP2B3A antibodies. We talked earlier about how the 2B3A receptor is found on the surface of platelets, and so when antibodies bind to this receptor, platelets are consumed in the spleen. And this presents as isolated thrombocytopenia with or without evidence of bleeding. And by isolated, I mean that the white blood cell count and red blood cell count should be normal, and there should be normal coagulation studies as well. Immune thrombocytopenia can be a primary problem where it occurs in isolation with no associated condition, but it also often develops secondary to another condition, especially inflammatory disorders or viral infections. So for example, you can see ITP in patients with CLL and lupus. You can also see it in association with a number of viral infections, including HIV, Hep C, CMV, and varicella. And so at the time of diagnosis, most patients are screened for HIV or Hep C infections because these are commonly associated with ITP. And then other testing for associated conditions is done only if the clinical features are suggestive. So for example, you might do an ANA for lupus if the patient had clinical features of lupus. ITP is a diagnosis of exclusion. There's no reliable antibody test. Even though, like I told you before, antibodies are often involved, they are not identified in many patients, and so you can't rely on them. So to make the diagnosis, the patient has to have isolated thrombocytopenia, a normal white cell count and red cell count, and there can be no other cause of thrombocytopenia, including drugs that might be leading to low platelets. Let's talk about the treatment of immune thrombocytopenia. So first of all, you should be aware that this is a different condition when it occurs in children compared to adults. In children, immune thrombocytopenia often resolves spontaneously. In addition, children, like these guys on the screen here, usually develop only mild thrombocytopenia and their risk of bleeding is lower. So in most cases for children, they're observed and their platelet count is monitored, but they don't require any additional treatment. And in general, children are usually only treated if they have a major bleeding episode or they're going to have surgery where a low platelet count might be dangerous. In contrast, when immune thrombocytopenia develops in adults, it's often a chronic condition that does not resolve spontaneously, and it often leads to persistent thrombocytopenia that requires therapy. So in terms of treatment for adults, first of all, you want to know that if the platelet count is above 30,000 and there's no bleeding, usually this condition is just observed, and it's high yield to know this for your boards. In general, the treatments for immune thrombocytopenia are restricted to situations where the platelet count is below 30,000. The first-line therapy is corticosteroids. This will suppress the production of antibodies and therefore it will lead to a rise in the platelet count. An alternative treatment is intravenous immune globulin or IVIG. IVIG is pooled antibodies from donors and it blocks Fc receptors on macrophages, and these are the receptors that bind platelets and lead to platelet consumption in the spleen. So by blocking those receptors, IVIG diminishes the destruction of platelets in the spleen. And then finally, for refractory cases, sometimes splenectomy is performed. If you take out the spleen, you will stop the removal of the platelets and the platelet count will go up. And then platelet transfusions are sometimes used if there's severe bleeding, but outside of severe bleeding, usually platelets aren't the ideal therapy. Instead, you want to do something that causes the spleen to stop destroying the platelets in the first place. Okay, next let's talk about thrombotic thrombocytopenic purpura, also known as TTP. TTP is an example of a thrombotic microangiopathy. These are disorders that involve small vessel thrombus formation. And in TTP, what's known as platelet-rich thrombi form in small blood vessels. These are blood clots that contain lots of platelets, so this consumes platelets in the circulation, leading to thrombocytopenia. And the cause of TTP is decreased activity of the von Willebrand factor cleaving protease called ADAMTS13. So to understand what ADAMTS13 does and how this is related to TTP, you need to appreciate that von Willebrand factor is stored in cells as large multimers, which are collections of von Willebrand factor molecules lumped together. These large multimers are secreted into the plasma by endothelial cells, and they remain attached to the endothelial surface for a period of time. What ADAMTS13 does is it cleaves the large multimers so that von Willebrand factor molecules can be released into the circulation, and in doing so it prevents large multimers from accumulating on the endothelial cell surface. This is especially important in small arterioles and capillaries. In these blood vessels, there's high shear stress as blood flows through the vessel, and this promotes platelet aggregation. So if those multimers persist on the endothelial surface and you have the shear stress of small arterioles and capillaries, this leads to thrombus formation. And that's what happens in TTP. There's deficient activity of ADAMTS13, and that leads to small blood vessel thrombus formation. So the cause of TTP is a severe ADAMTS13 deficiency. Usually the activity level of the enzyme is less than 10% compared to normal. And the usual cause of this problem is an acquired autoantibody to ADAMTS13. When these antibodies bind to ADAMTS13, it stops working. This results in persistence of large von Willebrand factor multimers in small blood vessels, which are areas of high shear stress. And that results in blood clot formation and obstruction of small vessels. In the video on extrinsic hemolysis, I talk about microangiopathic hemolytic anemia, also known as MAHA, and this is a major feature of the clinical syndrome of TTP. In microangiopathic hemolytic anemia, red blood cells are sheared as they pass through small blood vessels that contain thrombi. This leads to non-immune hemolytic anemia, so all the features of hemolytic anemia will be present. There will be anemia, high LDH level, high bilirubin, a low haptoglobin, the reticulocyte count will be up, but the Coombs test, the direct antiglobulin test, will be negative, and that's because this is a non-immune hemolytic anemia not mediated by antibodies to red cells. On peripheral blood smear, the classic finding in MAHA is the presence of schistocytes. This is one shown on the slide here. It's a fragmented red blood cell. And you can see microangiopathic hemolytic anemia in several disorders. One of them is TTP. You can also see it in HUS and DIC, which we'll talk about later in this video. In terms of clinical features, TTP can present with petechiae and purpura and bleeding, and this is all related to thrombocytopenia. Patients can also have fatigue and dyspnea from the anemia. And then thrombus formation in TTP often involves small blood vessels in the brain, so this can lead to neurologic symptoms like headache, confusion, seizures, or stroke. Fever is seen in some cases. It's considered one of the classic features of TTP, although it's actually only present in a minority of cases. And then finally, the renal function is usually normal. Later in this video, we'll talk about a syndrome related to TTP called the hemolytic uremic syndrome. In that disorder, there's often acute kidney injury, but usually the renal function is normal in patients with TTP. The way the diagnosis of TTP is usually made is that the patient's symptoms lead to a CBC and a peripheral blood smear. And these tests show evidence of microangiopathic hemolytic anemia plus thrombocytopenia. So you will see things like increased reticulocytes and increased bilirubin and schistocytes on the blood smear. And so once you have MAHA and thrombocytopenia, that's when you start thinking about TTP. You can confirm the diagnosis by doing ADAMTS13 activity testing. Usually the activity level is less than 10% of normal activity. Now importantly, you don't have to wait for the ADAMTS13 activity level test to come back to initiate therapy. We'll talk about this in a minute, but early therapy can be life-saving, so you don't want to delay therapy while you're waiting for this testing to come back from the lab. The coagulation times like the PT and PTT should be normal, and this is in contrast to DIC, which we'll talk about later. In DIC, the PT and PTT are elevated. And then finally, you can see an elevated D-dimer. The D-dimer indicates thrombus formation and breakdown, and so it can be elevated because of the microangiopathic hemolytic anemia. The treatment for TTP is with plasma exchange, also known as plasmapheresis. This is a picture of a plasmapheresis machine on the screen here. What it does is removes the patient's plasma and then replaces it either with donor plasma or a plasma substitute. And by doing this, it removes the antibodies that are causing TTP. There's a very high mortality to TTP without plasma exchange. And so as I mentioned on the last slide, treatment should not be delayed. If the patient has a classic clinical presentation with evidence of microangiopathic hemolytic anemia, you can start plasma exchange. You do not have to wait for ATF-13 testing to come back from the lab. It's very high yield to know this for your board exams. Beyond plasma exchange, glucocorticoids can also sometimes be used, and the platelet count is monitored to determine the efficacy of treatment. And then you should also be aware that transfusion of platelets is not often used in TTP. First of all, the incidence of major bleeding is very low, but beyond this, transfused platelets will just get destroyed like the patient's own platelets. So usually the treatment of choice is plasma exchange, and platelet transfusions aren't particularly helpful. If you understand TTP, then it's very easy to understand hemolytic uremic syndrome, also known as HUS. HUS is also a thrombotic microangiopathy like TTP. It's also caused by platelet-rich thrombi in small vessels that lead to microangiopathic hemolytic anemia and thrombocytopenia. HUS has the word uremic in its name because acute kidney injury is very common, and as I said before, kidney injury is uncommon in TTP. And also in HUS, you rarely see fever or central nervous system symptoms, but as we talked about earlier, these can be present in TTP. HUS often occurs in children, and it commonly follows a gastrointestinal infection with a form of E. coli called E. coli 0157H7. This form of E. coli produces a toxin called a Shiga-like toxin, and this toxin causes microthrombi to form. So the cause of the small vessel thrombi in HUS is the Shiga-like toxin from E. coli. It's not decreased activity of ATF-13. And the treatment for HUS is supportive care. It involves transfusions, dialysis for renal failure if it gets severe. Importantly though, in HUS, plasma exchange has not been found to be effective, so plasma exchange is not a treatment for HUS. Okay, next let's talk about disseminated intravascular coagulation, or DIC. In DIC, there's widespread activation of the clotting cascade, and this leads to the diffuse formation of thrombi in vessels throughout the body. These thrombi involve platelets and fibrin, and when they form, they lead to ischemia. Because of the widespread formation of thrombi, there's consumption of clotting factors and platelets. So consumption of clotting factors leads to prolongation of the coagulation times, like the PT, PTT, and INR, and consumption of platelets leads to thrombocytopenia. And then finally, thrombi in small blood vessels leads to microangiopathic hemolytic anemia in DIC, the same way this occurs from thrombi in small blood vessels in TTP and HUS. DIC occurs secondary to another process. A classic trigger for DIC is sepsis. Some bacteria possess endotoxin, and this can trigger DIC. It can also be triggered by cytokines from the inflammatory response that's part of sepsis. DIC is also a feared complication in obstetrical emergencies. So amniotic fluid contains tissue factor, which can activate the clotting cascade. So DIC is seen in conjunction with amniotic fluid embolism and can also occur in other obstetric emergencies. And then finally, many malignancies can potentially lead to DIC. DIC is a clinical and laboratory diagnosis. It requires an appropriate clinical setting, for example, sepsis, and then you need the appropriate lab findings. Those are the findings of microangiopathic hemolytic anemia we talked about earlier, plus prolongation of the coagulation times like the PT, PTT, and INR. Beyond this, the platelets will be low. There's low fibrinogen. Fibrinogen is a clotting factor, and it will be low from consumption. And then there's an elevated D-dimer because thrombi are forming throughout the body. The mainstay of the treatment for DIC is to treat the underlying disorder. For example, if patients have sepsis and DIC, if you can resolve the sepsis, the DIC improves. Beyond this, the treatment is with supportive care. Patients may require blood or platelet transfusions, and sometimes they're treated with fresh frozen plasma, which can replace lost clotting factors. Okay, I'll finish with this one slide which summarizes how to distinguish the different causes of thrombocytopenia that we've talked about in this video. So when patients have low platelets, you want to then look at whether or not they also have evidence of microangiopathic hemolytic anemia and whether the coagulation times are increased. In ITP, there's isolated thrombocytopenia, so none of these things should be present, and the white blood cell count and the red blood cell count should be normal. In TTP and HUS, remember those are disorders where platelet-rich thrombi form, so this causes thrombocytopenia. It also causes microangiopathic hemolytic anemia, but the coagulation time should not be prolonged in TTP or HUS. And then remember, TTP often presents with CNS symptoms. It can present with a fever. In contrast, HUS usually presents in a child after a GI illness with E. coli. And then finally, in DIC, remember the thrombi that form contain platelets and fibrin, so you see low platelets, microangiopathic hemolytic anemia, and coagulopathy with prolongation of the PT and PTT. And that concludes our module on thrombocytopenia.